Welcome to our soft tissue handling and dissection module. I'm Dureti Fufa from the Hand and Trauma Services. In the next part of this module, we're going to practice doing an approach utilizing the forearm in order to review some steps of soft tissue handling, including planning the incision, making the incision, performing dissection while respecting the soft tissues appropriately, principles of retraction, as well as wound closure. Okay, so to start planning our incision, oftentimes we plan our incisions based on known anatomic landmarks. In this case, I've drawn a line from the palpable radial styloid. The patient's thumb is down here at this end of the wound, and the patient's elbow is up here. So my incision is from the radial styloid to the lateral epicondyle. In making our skin incision in this area of the body, I'm going to utilize a 15 blade. I think a 10 blade is also appropriate in this area, really up to a surgeon's choice. As I mentioned previously, the 15 blade is typically held like you're holding a pencil, whereas in the use of the 10 blade, people typically suggest using it as if you're holding a violin bow. I'm going to use a 15 blade just because it's my preference. Oftentimes, obviously you're holding the scalpel in your dominant hand. Oftentimes people use their non-dominant hand to create tension across the wound as they're cutting. Tension across any plane in which you're dissecting increases the ease of your dissection. The first key in making an incision is making your incision exactly perpendicular to your skin edge and avoiding being oblique in any way to that. So in making my skin incision, the goal is to get through the dermis in one slice without having to go back and make that cut several times. At the beginning, you're obviously going to be hesitant because you don't know how much pressure to apply. Everybody's tissues are different. And so it's okay to be cautious. We'd rather have you have to make multiple passes with your scalpel as opposed to cutting too deep and cutting any veins or nerves that lie too superficial in your field. So in making my incision, again, I'm making sure that my blade is exactly perpendicular to my tissue. I'm holding my scalpel as if it's a pencil, and I'm using my non-dominant hand to create some tension across the wound to assist me. We can see subcutaneous fat all along the way here, indicating that I've gotten all the way through the dermis. Again, as I go, I'm using my non-dominant hand to help me create tension across the wound, which helps to control better the amount of pressure I'm putting in a downward direction. So we've separated the dermal layer all the way across. After making the incision, we're going to need to dissect through the subcutaneous tissue down to our first level, which in most parts of the body is going to be some form of fascia. We have multiple options for how we dissect. Dissection can be blunt, using your finger. It can be blunt, using a sponge in order to help us in an atraumatic fashion, okay, to clear some of the tissues. And you can see in this cadaver, with blunt dissection alone, I'm able to get down to the level of the fascia. So blunt dissection is one means of dissecting. Sharp dissection is another. I'm going to utilize a Metzenbaum scissors for our to demonstrate dissecting using scissors, a form of sharp dissection. You always want to have your two hands active when you're operating. So your dominant hand is going to be doing the work of the dissection, but in your non-dominant hand, you want to have a retractor, or your fingers are being held to retract. But we don't ever want to see you with one hand that's idle, okay? So I have a toothed forceps that's going to allow me to grab the deep subcutaneous tissues to help to manipulate and hold, to bring the tissues to where I want them to be for dissection. Again, your forceps in your non-dominant hand is most typically used like a pencil, okay? In dissecting using scissors, most commonly we put the curved tip of our scissors down towards the tissues that we're dissecting. That's not a rule 100% of the time. But these types of Metzenbaum scissors are designed with a blunt edge so that you're not going to be able to cut or traumatize anything that's deep. In dissecting with scissors, you want to spread in order to bring the tissues apart. When you're spreading, typically your hand is in a pronated manner, okay? And you spread and whatever falls away, and then we have something that's dense here, okay? Then when I want to cut tissues, I can see that there's not a nerve or a major blood vessel here. When I want to cut it, I switch from pronating to supinating in order to bring my scissors perpendicular to the tissues that I want to cut. And now we're at that same level of the fascia here. So again, when you're spreading, I'm using my forceps in this case to help show me tension or to help retract. Maybe my assistant would be helping me retract on the other side. I'm using my scissors to spread tissues that fall away easily and tissues that don't fall away. I know there's something structural there. That structural is going to be either fascia, or it's going to be a nerve, or it's going to be a vein that I might have to cauterize in order to avoid bleeding. But again, you spread and then you cut with your scissors perpendicularly by supinating your hand slightly. Now that I've cleared my fascia a little bit, I can clear it more with blunt dissection by using the sponge in order to facilitate. A couple of things you want to avoid are working in a haphazard fashion. So you can see here I've gotten to one layer, then I've progressed, get to that layer, then I progress, get to that layer. Some of the things that we see people do when they're early on is spread here, and then spread here, and then spread here, and you're making progress, but it's in a haphazard way. You don't really get a sense of what you're doing is done in a logical way. So you want to progress along your wound. Here I'm able to just bluntly spread, just this thing wants to hold up and I cut. I'm just marching along in a very systematic way along the wound, using my other hand with the forceps to help me with retraction. Okay. The other pitfall that sometimes people get into is working in a hole. You can see that I've opened up this whole window where I can see the fascia. We want to clear the whole fascial layer before I start to dive deep to the fascia. So for example, if I go in here, I start to come down and I want to find the fascia. I'm only clearing this small area here. I've got the fascia there, and it would be a mistake now to cut the fascia and to try to keep going deeper at this level because my window is very small. We want to clear this entire level of tissue before we progress to the next layer. Okay, again, I can finish whatever's remaining on here with some blunt dissection with my sponge in a very atraumatic way. In this area, after we've made our skin incision, at the point at which I can no longer perform enough retraction for myself, we would bring in retractors. In this area, a common retractor to use might be the Sen rake. You can see that this blunt right angle edge of it is smooth and may not be able to hold tension on it if we really need to pull the wound open. As a result, this rake side can provide more friction for us. In this subcutaneous tissue, there's no particular neurovascular structure that I'm worried about, so using a sharp type of a rake would also be appropriate. Whereas deeper and around structures that we'll see later, that might not be as appropriate. The person retracting for you can help you by pulling tension across your wound, and I'm holding, now instead of using my forceps in my other hand, I'm holding the retraction on the other side. Whenever you have tension across your wound, it becomes easier for your tissue planes to become cleared. I'm going to clear this off there, and we're almost through our subcutaneous layer down evenly to the same layer. So I'm holding some intermediate tension of my own to help me. Here we see a vein. This may be difficult for you to appreciate, but we may demonstrate some principles while dissecting that vein as well. Here we've encountered a vein from the superficial venous system. When dissecting around longitudinal structures, we mean nerves and blood vessels. You want to be careful not to traumatize these to cause uncontrolled bleeding. For me, I prefer to spread in line with these types of structures. for a vein, for this vein, for example, when I spread in line, okay, not transversely to the vessel, but in line with it, I can see where there's tissue that wants to hold up. Those are going to represent small branches to the vein, okay? So here I'm spreading in line, I'm spreading in line, in line. This here tissue is holding up. I could spread in line easily there, I could spread in line easily there. This suggests to me that there's going to be a small branch here, and this we would coagulate with either bipolar or Bovie electrocautery, but I'm going to cut it in this case. Here, this branch is a little bit more obvious to see as I spread longitudinal, there's some tissue holding up here, and we can see here that this is another vein, okay? As I spread longitudinally, the tissues that are non-structural, the fat, the loose pieces of fascia, fall away quite easily, and only the real structures remain. And those structures then I pay particular attention to with what needs to be done with cautery. In this case, in order to facilitate my exposure, I'm going to take this branch, again, this would be cauterized in the operating room, so that this vein can then be maintained in my palmar skin in this case. In retracting around blood vessels, you want to be sure not to use sharp edges of retractors, but rather blunt edges for the retraction. So now that the wound is largely open, we can also utilize self-retaining types of retractors so that you can limit the amount of retraction that your assistant needs to do, or it just functions as another set of hands for you. Again, I'd like to see a little bit more of this fascia. I'm going to spread bluntly over my fascia before I finish this, and then I'm going to place my retractors in the subcutaneous tissue here. Now we have the fascia very well exposed here. I'm going to try to find the radial sensory nerve here, and we know that I should find it between deep to the brachioradialis muscle. To go to my next layer, in order to open a clean new layer, I'm going to incise the fascia sharply. Again, making sure that I'm coming perpendicular to my tissue. Then I lift my fascia layer up so that I can do my deeper dissection down to the radius. With this kind of a fine tissue, what may be useful is a skin hook for the retractor. So to demonstrate dissecting techniques around nerves and blood vessels, we're going to go to the volar side of the forearm and dissect around the radial artery and the median nerve. So I'm opening the fascia over the volar compartment longitudinally. There's the nerve. As I'm coming deep to the brachioradialis, I see a different nerve. So I'm going to spread longitudinally. Okay, this I've cut it distally here accidentally. This is the radial sensory nerve. Again, I spread longitudinally in order to dissect it free. Okay, now we're going to keep marching in the palmar direction. The next longitudinal structure that I would expect to see, and I'm trying to avoid injuring, is the radial artery, which is right here. To get around it, as I mentioned, I spread longitudinally. Where something is resistant to my longitudinal spreading in line with it, I want to identify it and cut it. So I'm spreading longitudinally, and now this is giving me some resistance. So I'm going to presume there's going to be a blood vessel in there, and I would coagulate with bipolar cautery to be able to spread. Again, everything's falling away easily here. This is the artery under me here. If I want some help with retraction at this point, I would use a smooth type of a right angle retractor to give me this tension across my vessel, light tension across my vessel. I spread longitudinally along the length of the vessel. Something is holding me up here. I'm going to presume it's a blood vessel, and I would cauterize this with bipolar cautery. Okay. As I get deeper, rather, in this wound, again, I'm lifting up this artery here. And my assistant has to do more traction in order to retract. I have to be careful of what structures I need to protect in this area. As we're going more palmarly, the main structure that I need to protect is the median nerve. And so as I'm coming here, I want to make sure that I'm telling my assistant not to use undue tension here, because it can cause a neuroapraxic or stretch type of a injury to my nerve. If I ever stop working in this deep hole, trying to get to the palmar surface, and I need to work back over here, I'm always telling my assistant to relax on the tension on that side in order to avoid putting unnecessary stress on the nerves.